long lecture, so bear with me. It's a heavy topic. So let's look at inflammatory bowel disease this afternoon. So when we hear of the term inflammatory bowel disease, it's not one, but a group of chronic disorders that are associated with inflammation or ulceration in the large and small bowel. And the two most common types are Crohn's disease and ulcerative colitis. So we'll spend a little bit more time discussing these two as the prototypes of this group of diseases. Ulcerative colitis is associated with ulceration, inflammation of the mucosa of the colon and the rectum, and it's usually in the form of characteristic ulcers or open sores, so to speak. Whereas Crohn's disease tends to be not just a mucosal disease, but a transmural disease, and may affect the entire GI tract, all the way from the oral mucosa to the small intestine, and on occasion, some part of the colon. So it is a transmural inflammatory disease. It tends to have skip lesions. So you have normal mucosa, skip lesions, the ulcers, and then normal mucosa. So in 50% of cases in Crohn's disease, it's ileocolic, so small and large gut, 30% ileum, and 20% only the colon. And because you can see that in most of the time it affects the small bowel, and then it's often referred to as regional enteritis as well. So these two diagrams are kind of representative. On the left-hand side is the Crohn's disease to demonstrate that it's more commonly or more often an ileocecal disease. But of course, as we have said, it can affect the entire GI tract all the way from the mouth. Whereas ulcerative colitis tends to be just large bowel, and we'll see that even that it's not necessarily the entire bowel in majority of cases. So other forms of inflammatory bowel disease include collagenous colitis, lymphocytic colitis, ischemic colitis, Behcet syndrome, infective colitis, such as, for example, amoebiasis, and other forms of infectious disease, then intermediate colitis. So we'll spend more time this afternoon looking at in detail both ulcerative colitis and Crohn's disease. And because they have certain things in common, but there are also disparities, we often tabulate the features. So the incidence, you can see that Crohn's disease is more common, slightly more common. Age of onset can be in the younger age group, can be in the older age group for the two of them. The highest incidence for inflammatory bowel disease for some reason appears to be in the Jewish community. The male to female ratio sort of more or less the same for ulcerative colitis, and more common, slightly more common in males for Crohn's disease than females. This doesn't even make sense, but anyway, they always put it that smoking may slightly prevent ulcerative colitis, whereas it's promotive or a trigger for Crohn's disease. Oral contraceptives doesn't appear to have a risk in ulcerative colitis. but the odds are increased. The odds ratio are increased for Crohn's disease. Appendectomy appears to be protective for ulcerative colitis, but has no impact on Crohn's. The frequency in monozygotic twins is about 6% in ulcerative colitis, but pretty high in Crohn's disease. And I think this is because of the genetic factors, and we'll see those as we discuss further. Whereas in dizygotic twins, then almost no risk for ulcerative colitis, and just marginally so for Crohn's disease. So let's look at the pathogenesis of Crohn's and ulcerative colitis. It's often said that the exact cause of these two diseases is unknown, but it appears that genetic factors may play a role, as well as immunological factors. We are now understanding better the gut microbiome and what role it plays in inflammatory bowel disease and general health. So yes, microbial factors do play a role, and psychosocial factors generally do appear to play a role in triggering inflammatory bowel disease. So for genetic factors, ulcerative colitis appears to be more common in those individuals who have DR2 related genes, whereas it's different for Crohn's disease, more common in those who have DR5, DQ1 alleles, and 3 to 20 times higher incidence in first-degree relatives. And that's why you saw for monozygotic twins in Crohn's disease appears to be pretty high at almost 60%. So how do immunological factors play a role in inflammatory bowel disease? It appears that there is a defective regulation of the immunosuppression, and activated CD4 cells activate other inflammatory cells, such as macrophages and B cells, or recruit more inflammatory cells by stimulation of homing receptor on leukocytes and vascular endothelium. This is the general pathogenesis of most inflammatory processes. So it doesn't look like it's any different, but it's what comes before the defective regulation of immunosuppression that is the problem. So this is the schematic diagram, I think it's from Robbins, to show probable molecular factors or immunological factors that are at play for these two diseases. So you start with genetic predisposition, and studies done particularly in monozygotic twins. So the candidate genes, luminoflora, seems to be the starting point, increasing the risk. Then there are various environmental triggers, such as non-steroidal anti-inflammatory drugs, acute infection, smoking, stress, and other psychosocial factors, which activate mucosal immune system. And then depending on what your genetic predisposition is, then either you develop Crohn's disease or ulcerative colitis. And this is the cascade, so to speak, that happens. And you can see there's a slight difference in where it starts for both for Crohn's disease and ulcerative colitis. So the cascade further down is slightly different, but the end result is really inflammatory bowel disease. Whereas for ulcerative colitis, you end up with crypt abscesses, inflammation and disruption of colonic architecture, generally a mucosal disease, whereas Crohn's disease, you end up with a transmural inflammatory process. So this is sort of a more schematic representation of just the previous slide. So you start off with normal gut, and where there is tolerance-controlled inflammation, environmental triggers causing acute injury. This is when the disease flares up, can go back to tolerance and healing, or the immunoregulation can fail with failure of repair. And then for the genetically predisposed or susceptible host, it goes on to a more chronic inflammatory bowel disease. So the macroscopic features of ulcerative colitis usually involves the rectum and extends proximally to involve all or part of the colon, and the spread or involvement is continuous. It may be limited, so limited colitis, so it may involve just the rectum or part of the rectum and the sigmoid, or the rectum, sigmoid, and transverse colon. And finally, it may involve the entire colon with backwash ileitis. And this is a sort of schematic representation to show where A is when you have just involvement of the rectum, B, involvement of the rectum and sigmoid colon, distal colitis, up to the junction of the sigmoid colon and the transverse colon. And then lastly, you have the entire pancolitis, entire colon, and backwash ileitis. With mild disease, the mucosa, the colon mucosa, is reddish with sandpaper appearance. That means sort of a fine granularity of the mucosa. With moderate disease, there is marked erythema, coarse granularity, contact bleeding, but still no ulceration. But with severe colitis, then you have spontaneous bleeding, mucosa is edematous and ulcerated, so-called collar button ulcers. And in long-standing inflammatory bowel disease or ulcerative colitis, then there's regeneration of the inflamed mucosa to form pseudopolyps. There may be mucosal atrophy, or often actually in long-standing colitis, there's mucosal atrophy and disorientation leading to precancerous conditions. So where you have chronic inflammation and destruction of tissue and regeneration, then the risk for cancer ensues. Eventually, all this activity of inflammation and healing and regeneration can lead to shortening and narrowing of the colon. And of course, with fulminant disease, then you can have toxic colitis with megacolon. So these are photos and photomicrograph of ulcerative colitis. There's ulcers and pseudopolyps due to the regeneration of the mucosa, and then a not very good photomicrograph, but I think I have better ones. So microscopic features, you have crypts. Crypts undergo atrophy, as you can see in this schematic representation. So these are the usual long crypts, but with chronic destruction, they undergo shortening and narrowing. There is erosion on the surface. The crypts are distorted. And in active disease, you have crypt abscesses. And generally, ulcerative colitis affects only the mucosal layer, so it doesn't affect the muscularis propria. It is not a transmural disease, it's a mucosal disease, which is very different from what we have in Crohn's disease. So there's diffuse mixed inflammatory infiltrate, and there may be basal lymphocytosis. Then, of course, there is destruction of the goblet cells, and that's part of the distortion and narrowing of the crypts. So this is another photomicrograph to show a tissue section, to show how you have ulcers, areas of regeneration, mucosal regeneration, forming pseudopolyps. So you have ulcer, a pseudopolyp, an ulcer, so skip lesions, another pseudopolyp, and notice that the muscularis mucosa is really not affected, and the periserosal fat is also intact. So this is a photomicrograph to show the diffuse florid chronic active inflammation. You can see mixed inflammatory cells, lymphocytes, plasma cells, macrophages, and lots of neutrophils. And you can see even crypt abscesses. There's crypt distortion, and there are even mitosis because of regeneration. So there's a lot of activity going on. So this is severe active disease. So we look at Crohn's disease now. Crohn's disease affects, as we said earlier, any part of the GI tract, and it can start in the mouth all the way to the anus, but generally, more frequently, it's a regional enteritis. The ileum is the most often affected in 50% of cases. So it is a transmural disease with segmental. It can be segmental with skip lesions, giving rise to a cobblestone appearance of the gut. There's creeping fat, adhesions, and fistulae. So this photograph shows the ileum, narrowing of the lumen. The bowel wall is thickened, and that's part of the reason why the lumen is narrowed. There is linear ulceration, unlike ulcerative colitis, where you have collar button ulcers, so-called sort of roundish ulcers. That's why they are called collar button ulcers. But in Crohn's disease, you have linear ulcerations and narrowing of the small bowel. So this again shows, demonstrates the terminal ileum, and characteristically in Crohn's disease, the lesions are segmental with intervening uninvolved skip areas. So this is part of the involved segment of the ileum. Here, the normal mucosa. Serpiginous ulcers means sort of longitudinal narrow ulcers. And the fact that you have skip lesions also gives rise to the cobblestone appearance. So microscopic features of Crohn's disease, you have aphthous ulcerations, focal crypt abscesses, very similar to what you'd see in ulcerative colitis. Granulomas are often typical of Crohn's disease. In fact, it is one feature that differentiates Crohn's and ulcerative colitis. Ulcerative colitis, you don't see granulomas, but you do, they are characteristic in Crohn's disease. And then there is submucosal and subserosal lymphoid aggregates, and then transmural fissure formation. So Crohn's disease, once again, is a transmural disease. Okay, and here you can see sort of superficial as ulcers. There's diffuse inflammation of the mucosa, and then a granuloma with histiocytes, and even a giant cell in the middle. Clinically, ulcerative colitis presents with diarrhea, rectal bleeding, tenesmus, passage of mucus, abundant mucus in stool, and crampy abdominal pain. The diarrhea and bleeding is intermittent, often mild, and characteristically, patients may not seek medical attention for quite a while, but patients with proctitis may pass abundant fresh blood or fresh stained mucus, and this can sort of be alarming and therefore cause them to seek early treatment. They may also have tenesmus, urgency, and feeling of incomplete evacuation. And when there is proctosigmoiditis, it's associated with constipation and severe disease. The stools are liquid with blood pus admixed with fecal material. Physically, with proctitis, the anal canal is tender, and there is blood on the examination finger if you do a digital rectal exam. With extensive disease, there is tenderness on palpation of the colon. You can actually follow the sigmoid. If the sigmoid is involved, there is a tenderness on the left flank. If it's a transverse is involved, then the sub or infraumbilical region is very tender, and so on. Then if there is toxic colitis, there is severe pain and bleeding, and if perforation occurs, then of course there are signs of peritonitis, and it can be an emergency, a medical emergency. So we sort of grade the severity of ulcerative colitis into 4: mild, moderate, severe, and fulminant ulcerative colitis. In mild, the bowel motions may be less than 4 times in a day, whereas in fulminant ulcerative colitis, it may be more than 10 motions per day. And of course, bleeding is extreme in the fulminant ulcerative colitis, can be continuous, where in severe ulcerative colitis, it's frequent, and for moderate disease, it is sort of intermediate. For those patients with severe and fulminant disease, then they may have fever, and everything that comes with it, tachycardia, and so on. Hemoglobin generally is normal with mild disease, but in severe and fulminant disease, they may actually bleed enough to require a transfusion. And all the indicators, the lab indicators for an inflammatory disease are raised, such as ESR and CRP, and all those are increased. And of course, peripheral blood counts, white cell counts are increased. Clinical signs, we've already mentioned some of them: abdominal tenderness, and with fulminant disease, there may be even distension, especially if there is peritonitis. At a glance, ulcerative colitis and Crohn's disease. So on the left is Crohn's disease, and on the right, ulcerative colitis. So Arthur's sores in the mouth, primary sclerosing cholangitis may accompany inflammatory bowel disease. There may be skin symptoms of diarrhea with blood and mucus, anemia, depending on how severe the disease is, fever, we've seen that, abdominal pain. Often both Crohn's and ulcerative colitis may be associated with arthralgia and arthritis and weight loss, because obviously they're losing, they're not eating at that time, and they're pretty ill. So lab investigation and diagnosis of inflammatory bowel disease. Laboratory tests, they are those that we have already mentioned them. For example, you want to do a hemogram to show there is anemia and raised in white cell count. ESR will be raised, and CRP will be raised. Then endoscopy is a must, endoscopy and biopsy. First, not only to determine what part of bowel is involved, how severe the disease is, and then to take a biopsy for histological diagnosis. Imaging may be useful, particularly where they suspected toxic colitis and megacolon and perforation of bowel. It's very important to do imaging. So the laboratory tests, I think we've already mentioned, but just to recap, a hemogram will be useful. C-reactive protein generally increased, ESR is increased, platelet count is increased, hemoglobin is decreased because they are bleeding. Fecal calponectin levels correlate with histological inflammation and predict relapses and detect pouchitis. So this sort of your toolkit for lab investigation. Then imaging. We don't do much of barium enemas anymore because of endoscopic capability these days. So do enemas and emptying, preparing the gut for endoscopy, and then to take a biopsy. But where endoscopy is not available, by all means, a barium enema may be useful. It will show mucosal granularity, like we talked about in ulcerative colitis. In mild and moderate disease, there's mucosal granularity, which varies according to the severity of disease. Ulcers, and for ulcerative colitis, the collar button ulcers, and pipe stem appearance with loss. This is normal with the usual frustrations, but this in the sigmoid and rectum, they are lost, and it's described as pipe stem appearance due to the loss of and the normal colon frustrations. The narrow and short colon has a sort of ribbon-like contour. Sigmoidoscopy is generally abnormal. Loss of vascular patterns, granularity, there's friability, and of course the ulcers, the classical ulcers are seen in on endoscopy. So this is a healthy colon with a smooth mucosa, normal vascular pattern. But here there is erythema, there is mucosal edema, and then you start to see the ulcers and these pseudopolyps and just distorted in this colon with ulcerative colitis. And you can see the granularity that you don't see in a normal colon mucosa. Complications of ulcerative colitis, with all that going on, the chronic, the acute inflammation that goes on to become chronic, and there are relapses and healing and so on. The risk for cancer is real. Perforation, because there's mucosal atrophy and severe thinning, and strictures and adhesions, toxic megacolon, pseudopolyps, hemorrhage, and chronic anemia, hemorrhoids, and then uveitis, Pyoderma gangrenosum. So you have these ulcers, particularly in lower limbs, erythema nodosum, arthritis that resembles rheumatoid arthritis, fatty liver, and sclerosing cholangitis. All these complications of ulcerative colitis, both systemic and local complications. This is a photo of Pyoderma gangrenosum, so a wound with gangrene of the skin, epidermis and dermis. And of course, they tend to be present in the lower extremities. Extraintestinal or systemic manifestations, we already mentioned some of them. Eyes, you can get panuveitis, stomatitis, and Acher's ulcers, fatty liver or steatosis, sclerosing cholangitis and gallstones, kidney stones, hydronephrosis, fistulae, and recurrent UTIs. The skin, we've already seen Pyoderma gangrenosum, erythema nodosum, joint spondylitis, sacroiliitis, peripheral arthritis, and circulation phlebitis may be seen. Is it not moving? Okay. So for Crohn's disease, when you have just the regional ileitis, then of course you have abdominal pain, diarrhea, and it's a chronic inflammatory bowel disease, or inflammatory bowel disease. So weight loss is not uncommon. They may have low-grade fever. The disease, if it's jejunal ileitis, then a malabsorption occurs and steatorrhea. If the colon, if there's colitis and perianal disease, there's bloody diarrhea, passage of abundant mucus, there is lethargy and malaise, anorexia, and weight loss. Laboratory diagnosis for Crohn's disease, endoscopy, radiology, or imaging, biopsy is important, and CT enterography can be done. For laboratory investigation, CRP is elevated, ESR is elevated, varying degrees of anemia, leukocytosis, and hypoalbuminemia because they are losing protein in the diarrhea. The so-called stick sign in barium or string sign in barium. You can see this sort of narrowing, so that the barium it just appears as a string, so string sign in the ileocecal region. Colonoscopy is part of the armamentarium, so to speak, for diagnosis of inflammatory bowel disease, just like for ulcerative colitis. It's also standard for Crohn's disease. Not a very good image on the right here, but it's supposed to show some ulcers. And again, I think I enlarged the image so much we lost some detail. So I won't even attempt, but you can probably see severe ulcers in this column, in these images. So intestinal complications for Crohn's disease, again, because of the chronic inflammation, tissue destruction, and regeneration, the risk for cancer is real. Fistulae, because of it's a transmural disease, you may have perforations and abscess formation, and strictures because of narrowing of the gut. So treatment goals for inflammatory bowel disease. Obviously, the ultimate treatment goal would be a cure, but that may not always happen. But stepwise, you want a clinical improvement for your patient. You want to get the patient into remission. Then you want to wean them from steroids, because that is what is one of the mainstay of treatment, glucocorticoid steroids, maintenance of remission, maintain tissue healing, and ultimately to get your patient into a cure. So treatment, not use many modalities. Remember, we don't quite understand what the etiology is. If we did, probably a cure would be easy to find. So many things are used in order to manage the disease. So dietary change, because some diets are triggers for inflammatory bowel disease. Some drugs, such as we've seen non-steroidal anti-inflammatory drugs, lifestyle change, so that to a lifestyle that is less stressful, so because we know stress and psychosocial stress can be triggers for inflammatory bowel disease. Then worst case scenario, where you have fistulae and narrowing colon or megacolons, those may require surgical intervention. Or if you have severe disease, fulminant disease, for example, that is life-threatening, then surgical intervention may be the treatment of choice. So lifestyle changes includes taking adequate rest, exercise, not smoking, stress reduction, avoiding non-steroidal anti-inflammatory drugs, and then, of course, for pharmacological management of inflammatory bowel disease, we use agents that are related to aspirin, 5-acetyl salicylic acid agents. They're available in the market. Glucocorticoids in the acute phase, antibiotics to reduce the risk of opportunistic and secondary infection, immunosuppressants. They are now designer drugs that are immunomodulators, not really immunosuppressants, but immunomodulators that are in the current market to manage particularly ulcerative colitis and Crohn's disease. And then biological therapies. Some of these probably experimental, but certainly glucocorticoids or a variety of steroids and immunomodulators are pretty effective. Examples of 5-acetyl acid agents include sulfasalazine, which is a combination drug, mesalazine, such as asacol, and mesacol is another one that is common in the market, and a variety of others that are also used in our market to treat and manage inflammatory bowel disease. A lot of these 5-acetyl acid agents act locally. So the topical action, so taken orally, and slow release, so they act where they're supposed to be and not absorbed systemically. In the severe disease, liquid enemas may be used and suppositories, but here you have limited disease, the proctitis in ulcerative colitis. Suppositories and liquid enemas may be useful. Pharmacological agents are useful in mild to moderate disease of ulcerative colitis and Crohn's. In maintaining remission, may reduce, because they reduce inflammation, they reduce the risk of colorectal disease, or colorectal cancer, sorry, and they also help manage adverse effects. Then, of course, they have to be used carefully because they may be associated with nausea, headache, epigastric pain, diarrhea, hypersensitivity, reactions, and pancreatitis. And they should be carefully used in the presence of renal impairment, pregnancy, and those who are breastfeeding. Glucocorticoids, which are the mainstay of management of inflammatory bowel disease in the acute phase or in flare-ups. They are useful for moderate to severe disease. They act by inhibition of inflammatory pathways. I'm sure you know this from your pharmacology. And two examples are budesonide and prednisone that are used pretty high dose to begin with, and then they are tapered off. They are never used in maintenance therapy because of all the side effects and complications of long-term steroid use. Antibiotics generally are not used in the quiescent disease, but metronidazole is effective in active inflammatory disease where there is fistula and perianal disease, particularly Crohn's disease. And then some antibiotics such as ciprofloxacin when required or as indicated in the acute phase. Immunosuppressants, useful in long-term management of severe disease. Remember that pyramid, you want to maintain healing and reduce inflammation in the long term. Cyclosporine, one of the ones that is used for long term, prevents clone expansion of T cell subsets. This is really now pharmacology, especially where you can't use steroids, and they're useful in both active and chronic disease because the side effects of cyclosporine, quite a number there. remember I talked about immunomodulators, and one of the ones that is pretty new in the market in the last few years is infliximab. It's an anti-TNF monoclonal antibody, and that's how it acts. It binds TNF trimers with high affinity, and it also binds to membrane-bound TNF alpha, neutralizes its activity, and also reduces TNM serum levels. Useful in fistulizing Crohn's disease, severe active Crohn's disease, refractory and intolerant, those who are refractory intolerant of steroids or immunosuppressive therapy, but then they are not without side effects. And generally, they are not used continuously. So you may give 2 monthly, a large bolus dose 2 monthly. That's what you give the body time to recover, and that is useful to reduce inflammation and achieve remission quite quickly. Other medications that may be useful, of course, are antidiarrheals during the acute phase, laxatives, and again, these are not drugs that you use all the time. It's intermittent management as indicated, pain relievers, supplements because of to manage anemia or chronic blood loss, and nutritional management. So both, I think we've already mentioned, both ulcerative colitis and Crohn's disease. In severe fulminating disease, they may require surgery. Those with chronic disease, with intractable anemia, tenesmus, patients with steroid-dependent disease, because you want to wean them off and not get into the problems of chronic steroid use. Risk of neoplastic change, extraintestinal manifestations, the ones we've already mentioned, skin, eye, liver, kidney, systemic disease, and where there is severe hemorrhage or stenosis, megacolon, and so on, there's a role for surgery. So it's generally reconstructive surgery or proctocolectomy, and with ilioanal pouch. So they are also, it really depends on where the disease is and the severity of disease. Then the surgeon sort of plans the surgery accordingly. Others forms of surgeries may take the form of proctocolectomy. That means removing the rectum and part of the affected colon, ileostomy, rectal and anal dissection, colectomy with ileorectal anastomosis, and so on. Again, really depending on extent and severity of disease. Crohn's disease surgery generally takes the form of ileocecal resection or segmental resection, depending on the affected part of the bowel, colectomy and ileorectal anastomosis, temporary loop ileostomy, and so on. And then, of course, if there are strictures, strictureplasty, and so on. Okay, and I'll not go into this. This is just some examples of how the surgeon may remove a stricture. So it's rather long and mouthy. I'll sort of leave it there. Any questions? You've done pretty well in 1 hour. Actually, I thought I would take longer than that. Any questions? Any comments? So my expectation of you is to know, I'm not worried if you don't know this, the infrequent examples of inflammatory bowel disease, but expect you to know Crohn's disease and ulcerative colitis very well. We have some examples of gross specimens in the museum, both Crohn's and ulcerative colitis. So when you are at the medical school, spend some time there and have a look at those two so that you can see the cobblestone appearance, the skip lesions, the transverse or longitudinal ulcers, and so on. Okay. I'll ask Robert to take out some of the pots for you and put them on the bench. Any questions? Any comments? I can see some two chats. Oh, sorry, Khan, I was not host, so I couldn't.
It's okay. I fixed it.
Okay, all right, thank you. Somebody is asking, redemonstrate string appearance, pipe stem. Okay. Let me start sharing again. The string sign. Somebody's asking about the string sign. Here is a string sign. You see a string. Well, you see the barium here. The barium is filling the gut, but here because the cecum is so narrow that there is only a trickle of the barium enema, so it appears as a string. See that? I hope you can appreciate it better. Does that answer your question? Whoever had asked the question, I hope. Okay. Any other question? Huh? How do the two conditions lead to cyanosis? Can somebody answer that one? Can somebody try and figure it out? Oh, and then the pipe stem. Oh, here. Okay, somebody is asking about the pipe stem. See, this is the normal frustrations of the colon when you have a barium enema. You can see this sort of in-out lacy pattern, but here it's gone. Huh? It's just a pipe, yeah, with no features. Okay, that's why it's called a pipe stem, like a water pipe. Yeah, it's just straight. That's why it's called a pipe stem. Yeah, and then you can see the ulcers in this. Okay, the so-called collar button ulcers. If you think about a collar with buttonholes, yeah. So these are the holes, like the collar of a shirt with holes for the buttons. Yeah, those are the collar button ulcers. Any other question? When do patients undergo protolectomy? Protolectomy is removal of the rectum. If it's so severely inflamed, and maybe there are fistulae and there is perforation, then you may just want to remove the colon, the rectum. Yeah. there's minimal absorption of water and nutrients in the rectum, so they won't suffer any fluid and electrolyte imbalances if their colon is, their rectum is removed. Okay, so they still have the rest of the colon. I think I've already explained the pipe stem. The mechanism of extraintestinal manifestations is thought to be autoimmune. So you have an autoimmune arthritis, arthralgia, skin lesions, and uveitis, the panuveitis, they're all autoimmune. Remember, we said that it's thought that the problem, why it goes on to become systemic disease. Let me just go back to the pathology here. So you have all this, the normal immune response through the activation of APC